Good morning, everybody. Thank you for joining our meeting today. I'm Dr. Leanne Godino. I'm a physician at Extreme Medi Clinic. Our presenter today is Dr. Agnes Magwete. She is an experienced chemical pathologist with over 26 years of expertise in the medical field. She is currently based at AMFAS Private Laboratory, where she serves as a consultant pathologist for the Gauteng North region and the National Reference Laboratory. Dr. Magwete's role involves overseeing standardization of chemical pathology reporting, introducing new diagnostic tests, and ensuring the quality control of laboratory processes. Her previous experience includes leadership positions at NHLS, Jane Hospital and Chris Bakani Baragwanath Hospital, where she was responsible for laboratory management, quality assurance, and training medical professionals. Dr. Magwete has also worked as a medical officer in internal medicine and pediatrics. Dr. Magwete holds an MBCHB and an MMed in chemical pathology from Medunsa and has completed management programs at Wits Business School and UNISA. Her research has been published in notable medical journals, with her recent work focusing on lipid analysis and iron studies. Thank you very much for coming to present to us. I'm handing over to you.
Okay. Thank you, Dr. Godino, for the kind introduction. So today we're going to look at the approach to hypercholesterolemia, and we're going to do it in a way of case presentation. So we know that hypercholesterolemia is one of the commonest metabolic abnormalities in clinical practice, associated with dire consequences. We know that, if it's not well managed, the patient may present with that debilitating atherosclerotic cardiovascular issues. And I think we all agree that prompt and accurate diagnosis of the cause of hypercholesterolemia with a targeted treatment is crucial in the attempt to avoid the unwanted outcomes. So today our discussion will be centered around two patients who present with unusual causes of hypercholesterolemia. These are conditions that are potentially treatable but can easily be misdiagnosed. And you know that it's a ripple effect. If you misdiagnose the patients, then it means you're going to mistreat these patients, and you're going to bring more harm to this patient. So today, at the end of this presentation, what I would have wanted to have achieved is to bring awareness of these conditions, and to also talk about how we go about making the diagnosis of these conditions, and also the importance of making the correct diagnosis for these conditions. So it's going to be in a way of a case presentation. So the first patient that I'm going to present today is a 26-year-old man. This man presented with a generalized weakness, with headache, abdominal, and neuropathic pain. So in the past medical history of note is that this patient has primary sclerosing cholangitis. This is a progressive disease of the liver and the gallbladder, where there is a progressive narrowing of your bile ducts. And this patient also had a past history of ulcerative colitis. So on examination, this patient, he had normal vital signs with the right upper quadrant abdominal tenderness. And he also had these multiple small yellow dome-shaped papules on his face and extremities. So you can see, you can see that on the, just kind of a pointer here. So you can see those papules on the face, on the elbows. You can see it also on the palms. So these are eruptive xanthomas. Okay. The laboratory investigation that was done on this patient, it was found that this patient has severe hyponatremia and also has got abnormal liver functions with a cholestatic picture. You can see that your total bilirubin is very high, with your ALP also very high. And then also they did the lipogram, where you can see that there is severe hypercholesterolemia with a total cholesterol of 66, and LDL, the direct, the one that was measured, that was just measuring as greater than 26. So this was severe hypercholesterolemia. So on interpretation of this result, we saw that there was hyponatremia. And after they have identified that this patient has got a severe hyponatremia, what they did was they tried to correct this hyponatremia with an isotonic saline. And then subsequently, when they saw that this patient is not improving, they even went on and gave this patient a hypertonic saline infusion, trying to correct this hyponatremia. But subsequently, then when they see that this patient is not responding, then they did the correct thing. They went and did their osmolality, serum osmolality, and they found that the serum osmolality, I think we saw that it was 283, so it's normal. So meaning that this patient has got pseudohyponatremia that is caused by this increased lipids in the system. And this we see in the laboratories where we use a method that is indirectly measuring the sodium, where we use water, as part of the calculation. So in patients with hyperlipidemias, there is displacement of this water, so the water content in the plasma. So when we calculate, then it will give us a falsely low sodium reading. So normally when you have a patient with a hyponatremia, before you start doing anything with that patient, make sure, confirm first that this patient has got a true hyponatremia, because it was not necessary for this patient to be given even the hypertonic saline, because it's also not without complications. And the other thing on the interpretation, we saw that there is elevated liver enzymes with a cholestatic picture. And this was indicated by that highly raised ALP and bilirubin. And then also there was this significantly elevated total and low density lipoprotein on lipid profile, and that is hypercholesterolemia. So at this stage, they made a differential diagnosis of familial hypercholesterolemia, which is, what you could have thought of, because this patient, is presenting with xanthomas, and now you saw that the LDH, is very high, with that total cholesterol of 66. But then now, if you are here, then you would want to go back, because there was no history in the, we were not given a history of dyslipidemia by this patient initially. So when you are here, then you would want to go back and check if there's a previous history of dyslipidemia, or there's a family history of dyslipidemia, if you would go along the lines of familial hypercholesterolemia. And the other differential here is obstructive liver disease. And in every patient with hypercholesterolemia, you would also want to exclude secondary causes, the most common secondary causes of hyperlipidemia. And in this case, you would want to exclude nephrotic syndrome or hypothyroidism. And in those results, we saw that glucose was normal. So they have already excluded diabetes mellitus as the cause of secondary hyperlipidemia. Okay, so on further evaluation of this patient, they sent a sample for lipoprotein electrophoresis. And then during that analysis, an abnormal lipoprotein was detected that is called lipoprotein X. And then they also did an ApoB, because with that extent of increase of LDL, you'd want to also see the corresponding increase of the ApoB, because ApoB is an apoprotein, apolipoprotein that is on the surface of LDL. So when you have that high LDL, then you would expect this patient also to have a very high ApoB. But in this patient, the ApoB was low. So there's something there. But there's also this lipoprotein X, abnormal lipoprotein that was detected. So they managed to rule out nephrotic syndrome because the kidney function, mainly here we're talking about protein urea, it was found to be okay. And then there was also no thyroid disease. Thyroid function tests were normal. Then they went and did this sodium, repeated the sodium on a direct ISE methods. This is, for example, your blood gas. So you can just take your sample and then just go and do it on your blood gas, because it's using a different method than the method that is used in the laboratories. So on this direct method, the sodium was found to be normal. All right. So this is the other way of confirming your hyponatremia. If maybe you think that your serum osmolality will take long, then just take a sample and then go and do a sodium on your blood gas and compare with the results that you have. Because if the sodium on the blood gas is normal, then that would suggest that the hyponatremia that you saw on the results is pseudo hyponatremia. So they went further and did a magnetic resonance cholangiopancreatography, which then confirmed those cholestatic results, the liver function test. So there was that showed a hepatosplenomegaly with intrahepatic and extrahepatic biliary stenosis. So our results, the liver function was confirmed here that the patient has got an obstructive jaundice. So the initial therapy, based on everything that we have, the initial therapy that was given to this patient, they don't say whether they gave this patient these drugs before or after they have identified that there was this abnormal lipoprotein X in the serum on lipoprotein electrophoresis. So they gave this patient atorvastatin, okay, to manage the hyperlipidemia. So atorvastatin, we know that its mode of action is to inhibit the HMG-CoA, the rate-limiting enzyme for the synthesis of de novo cholesterol. And then it also upregulates the uptake of LDL from the circulation into the hepatocyte. So it regulates the uptake of this LDL, and then the evolucumab, it's a PCSK9 inhibitor. So we know the role of PCSK9 in lipid metabolism is that it binds to the LDL, because you know that those LDL receptors are recycled. So after they have internalized the LDL cholesterol, then it internalize it, and then from there, after releasing it, it comes back to come and take again. So what happens is that the PCSK9 will then bind to these LDL receptors and then cause degradation. All right, so it decreases the number of your LDL receptors that are available for taking up the cholesterol. So if you give this patient this inhibitors of that thing, PCSK9, then you prevent the degradation of the receptors, and then you will have more of the receptors taking removing cholesterol from the circulation. But then they also gave the patient cholestyramine. Cholestyramine is a bile acid sequestrant. So, okay, these patients, I mean, they have a bile acids accumulation, and then they may present also with pruritus. So to treat those symptoms, you can give them the bile acid binders, yes, like this. So what they say is that after they have given this patient all this, this treatment failed to produce cholesterol reduction, or at least reduce the clinical, improve the clinical, picture of the patient. So then the patient was then admitted for total plasma exchange or plasmapheresis, and then he also underwent endoscopic retrograde cholangiopancreatography with biliary sphincterectomy, balloon sweeps of biliary tree, and serial balloon dilatations, as well as 2 sessions of total plasma exchange. So here they were dealing with the stenosis, or the cause for the cholestasis. And after they have done this, that's when they saw that the symptoms improved significantly, and his total cholesterol also decreased by about 87%. So 2 weeks after discharge, he reported no headache, and there was also improvement in his abdominal and neuropathic pain. And the symptoms also were slowly improving. And then also there was continuous reduction of liver enzymes and normalizing of sodium levels. So the liver biopsy that was done was consistent with primary sclerosing cholangitis, and there was no malignancy observed. And then the patient was then followed up with serial ERCPs, and the patient was considered for liver transplant as the definitive treatment of his condition. So here is an illustration of the patient who had a lipoprotein X-induced hypercholesterolemia. So this condition was described in 1969. This is after they have realized that there were the patients with obstructive jaundice were presenting with dyslipidemia, but they didn't know what was the origin of this dyslipidemia. And then they managed to also find out that there was some abnormal lipoprotein that was found in these patients, and they thought that it was an abnormal LDL, but later on they gave it a name. It was called the lipoprotein X. So this is an abnormal lipoprotein produced during cholestasis, all right? And it could be an intrahepatic or extrahepatic cholestasis. And it is rich in phospholipids and free cholesterol, with albumin as the main protein, and it also has apoprotein C on the surface. All right. So it is also understood that the formation of this abnormal lipoprotein X, is thought to be a protective mechanism against the toxic effects of the accumulation of excess free cholesterol. So we know that excess free cholesterol can only be cleared by the liver through enzymatically being converted to bile salts or by secretion into bile. But then now if there is cholestasis, that process is being hampered. And as a result, we will have this free cholesterol, which is toxic, finding its way back into the circulation. All right. So there in the circulation, what it does, it binds with the phospholipids in the circulation. It binds with your albumins there, and with minimal amounts of esterified cholesterol and triglyceride, and form this, what is called this lipoprotein X. So this is the pathophysiology of production of this lipoprotein X is during cholestasis. So what is found again is that it has a similar density as LDL. I'm sure that is why initially they thought that it was an abnormal LDL. It is because it has got the same density as LDL, and it is also found to interfere with the measurements of LDL, whether it be it direct measurement or calculated LDL. So, but unlike LDL, it doesn't have ApoB on the surface. Like I said, it only has ApoC on the surface. And as a result, it means that it's not going to be cleared by the LDL receptors as LDL is being cleared in the liver. So the main way of it being cleared is through the reticuloendothelial system, and primarily by the spleen. Okay, so lipoprotein X is often responsible for false elevations of LDL and should be suspected when there is unusual elevation of LDL with a low ApoB. Because with the extent of the raise of the LDL, you would expect the corresponding increase of ApoB. So in our patient, you saw that this patient had an LDL of greater than 26, but the ApoB was normal. Okay. And then lipoprotein S cannot be measured, unfortunately, by standard lipid panels, but it can be identified by doing further investigations, by sending your sample for a lipoprotein electrophoresis. That's where it can be detected. And we saw also in our patients that way they detected that this patient has got lipoprotein X. So it should be suspected when you see that there is discrepancies between your cholesterol and your LDL. So in the patients with a total cholesterol that is very high, but then with a low or low normal or low ApoB. So in that case, the total cholesterol to ApoB ratio will be significantly increased. They state it as it will be more than 6. And then you also have to suspect this when there is a discrepancy between direct and calculated LDL concentrations. So in our lab, what we normally see in these cases, because I think for now, for this year only, we have seen the cases that I am aware of, they are 4 of this kind. So what would alert us will be this dramatic increases of total cholesterol and LDL, but then you'd find out that the LDL is greater than the total cholesterol, which doesn't make sense because total cholesterol includes HDL and your LDL and your HDL. So in these cases, what we have seen in the lab is that your LDL will be more than your total cholesterol. So those are the times when you suspect that there is a lipoprotein X involved. And these patients, there will always be a history or there will be clinical signs and symptoms of cholestasis. So you will expect this in a patient who have cholestasis, be it intra or extrahepatic. So what are the complications of this lipoprotein X? So when it accumulates, then it circulates in your blood, and it can now deposit into your skin, like we saw in our patient. So it causes xanthomas. All right, and because of the sluggish movement of the of blood in the circulation, the patient may also present with thromboembolisms. Okay, and it's also associated with hyperviscosity syndrome, of which the symptoms of hyperviscosity syndrome are the same as the symptoms that can be given by a patient with hyponatremia. And maybe that is why this patient, they started treating the patient, thinking that maybe the symptoms that the patients were as presenting of, like your headaches, your generalized fatigue, neuropathic pain, were maybe because of that hyponatremia, but it was because of the hyperviscosity syndrome, because of these lipoprotein X. And this presentation of hyperviscosity syndrome is potentially fatal in this patient. So we have to be aware of that. And pseudonatremia is also one of the complications of lipoprotein X-induced hypercholesterolemia, and these patients may also develop cholesterolomas of the lungs. Okay, but even when these patients develop xanthomas, this lipoprotein X is not associated with increased incidence of coronary artery disease. Instead, it's been discovered that it is protective of the endothelium, because what they found is that this lipoprotein X, it prevents LDL to be oxidized, because we know that with the atherosclerosis formation, the first thing that happens is that these LDLs becomes oxidized and then they cause damage to your endothelium. So it was found that lipoprotein X prevents oxidation of LDL, and because of the high concentration of your phospholipids, this also causes, or preserves the integrity of your endothelium. So the standard cholesterol lowering drugs are ineffective in these patients, and they may carry the potential for toxicity because we have said that, your statins are working on your LDL receptors, they upregulate your LDL receptors. Your PCSK9 also works on the LDL receptors. Your ezetimibe works on what? On the preventing the absorption in the intestine of your cholesterols. But then we saw that lipoprotein X is produced. The pathophysiology is in cholestasis. So this treatment, they do not have any effect on this on these patients. So it was really not necessary for this patient to be given those statins and whatever that he was given. So plasmapheresis is advocated as a temporary measure for patients who present with complications like your hyperviscosity syndromes, okay? And then the definitive treatment in these patients with lipoprotein X-induced hypercholesterolemia is the treatment of the cholestasis itself, because it's with cholestasis where this lipoprotein X is synthesized. So if you treat the cause of cholestasis, then the lipoprotein X disappears and all the symptoms of that were presented will also disappear with that treatment. So the second patient that I'm going to present is a 58-year-old male patient who was referred to the lipid clinic for statin intolerance and history of genetic hypercholesterolemia. This patient had tendon xanthomas on the extensor surface of his hands and on the Achilles tendon. This is there's a tendon xanthoma there. And these xanthomas, of note, they were there since childhood. Okay, and this is just like his brother and sister. They had both had the same type of presentation, but the brother and the sister both died due to premature coronary arthritis. Okay, and he had biopsy of this Achilles tendon, and he was told that it revealed cholesterol by his surgeon, and he was not able to take simvastatin, atorvastatin, pravastatin, or rosuvastatin due to significant myalgia, and that is why this patient was then sent to the lipid clinic for lipid lowering management. So of note in the past medical histories that this patient had inguinal hernia that was repaired. He's got a history of dyslipidemia and also a moderate carotid atherosclerosis. Okay. And then of note in the family history is that he has two brothers who died of myocardial infarction at the age of 59 and 53, and a sister who died of coronary artery disease at the age of 56 years. And these are the xanthomas that were found on the hands. Okay, and the father who died at age 85 years with coronary artery disease. So on examination, this patient, what was remarkable was these xanthomas, but otherwise everything else looked a bit okay. So on the laboratory investigation, this patient had a total cholesterol of 6 with an LDL of 4. Okay, and from here, and then the TSH, glucose, they were normal. So they also excluded the secondary causes. So with the results that they had and the examination that they had, these were the differential diagnosis. They thought that this patient may have familial hypercholesterolemia because it looks like this patient had this disease from childhood, because we've heard that the symptoms were there since childhood. So, but it was ruled out due to the relatively low cholesterol levels, because we understand that even in the heterozygotes, for you to suspect that the patient has got familial hypercholesterolemia, the total cholesterol should be at least more than 6.5, and your LDL more than 5 at least. So they ruled out familial hypercholesterolemia based on the concentrations of the cholesterol levels. And then they also thought this could be cerebrotendinous xanthomatosis. This is a lipid storage disease, but it was ruled out also because this patient didn't present with other symptoms that are associated with this disease. And then what was the presumptive diagnosis was cytosterolemia, or what is known as phytosterolemia. But you can only come to this diagnosis if you are aware of this kind of diseases. If you are not aware of this, then because there are many patients who are being treated as familial hypercholesterolemia, even when there was negative genetic testing. So like this patient, I mean, you saw they said it was a query genetic dyslipidemia. So they couldn't even give it a name because I'm sure the genetic testing was negative. And in children, what they know, because I mean, okay, let's go. Let me not go ahead of myself. So what they did was that they also went, because they thought about cytosterolemia or this phytosterolemia, they went and did serum cytosterols in this patient. But then unfortunately, they did this test while the patient was already on ezetimibe. And despite being on ezetimibe, the plant sterols were still raised. So the elevation of plasma sterols, despite initiation of ezetimibe, strongly suggests that the patient has got cytosterolemia. All right. So what is cytosterolemia? This is a disease that, or a condition that was described in 1974. And this was found in two siblings who presented with xanthomas, but they had normal cholesterol levels. So they then did these serum plant sterol levels, and they found that this patient had increased levels. So that's how they came up with this diagnosis of cytosterolemia. So it's the xanthomas were formed by the deposit of or accumulation of those plant sterols. So it's an autosomal recessive lipid disorder, which is characterized by the accumulation of plant sterols in the blood and tissues, which, when left untreated, can lead to premature coronary artery disease and death. Okay, so the pathophysiology stems from the mutation in the genes that codes for proteins that are involved in the intestinal and hepatic excretion of this absorbed dietary plant sterols. That is sterolin 1 and sterolin 2, or ABCG5 and ABCG8. Okay, so normally what happens when we ingest these food that contains plant sterols? So once these plant sterols enters or reaches the intestinal mucosa, these proteins, sterolin 1 and sterolin 2, they pump these plant sterols back into the gut lumen for excretion. So normally we absorb less than 5% of this, and we cannot, I mean, as humans, we do not also synthesize these plant sterols de novo. All right. So these plant sterols are often consumed in nuts, in legumes, in seeds, avocados, and vegetable oils. And because this disease is an autosomal recessive disorder, so parental consanguinity increases the risk significantly. So it should be considered in patients who present with hypercholesterolemia with poor response to statin treatment. And once you give them, or maybe you add ezetimibe, then there's a dramatic response, to ezetimibe treatment. So then you should suspect that this patient may be having cytosterolemia. And then it also should be suspected in patients who present with xanthomas, but with normal cholesterol. All right, because normal cholesterol doesn't exclude cyclosterolemia, like you saw on those patients where it was discovered. These patients had normal cholesterol, but they had xanthomas. So they wanted to know what was the cause of the xanthomas. And they found that it was these plant steroids. And you should also expect it in patients with hypercholesterolemia who present with unexplained hematological findings. Like these patients will have what looks like hypercholesterolemia or familial hypercholesterolemia, but they will have hemolytic anemia that you cannot explain. Or they may have erythrocytes that have abnormal shapes, your stomatocytes. Or these patients may have thrombocytopenia with large platelets. Because it's also been said that some of the patients only presented, presentation into the rooms was with these hematological symptoms. So some of these patients may also present with arthralgia and joint pains, especially of the knees and the ankles. So the variability in presenting signs and symptoms and the low awareness by treating physicians, they say, contributes to missed or delayed diagnosis in these patients. And the prevalence of these diseases, the correct prevalence is not clear because it is understood that these conditions are being greatly misdiagnosed. Okay, so standard lipid profile again do not check for blood steroids in the blood. So the diagnosis is only made by demonstrating a raised plasma concentration of plant steroids, but you can only do this if you are aware of the disease. And it can also be confirmed by a genetic analysis of the mutation in those that protein, the genes that codes for that protein, the sterolin 1 and sterolin 2. But then false negative results when testing for plant steroids may be seen in patients who are already on ezetimibe, because like I said, once you give ezetimibe, then ezetimibe, it will prevent absorption, because in this patient, our problem is hyperabsorption of these plant steroids, and then there is reduced excretion. So once you attack it there, then this patient dramatically improves. All right. So if the patients are already on ezetimibe, you may have or you may get false negative results. And also the patients who are on a diet low in plant steroids, you may also find that you get false negative results. So in those patients with who are being, diagnosed as familial hypercholesterolemia, and they are on both your statins and your ezetimibe, so you will miss these cases because now they will respond to ezetimibe treatment. Even if, because most of the patients with what is called familial hypercholesterolemia, the genetic testing is negative. So the doctors are hoping that maybe there's another variant that is still to be developed, or discovered. But they forget that there are some of these conditions that are being said they are rare. So they don't even look for those conditions. So differentiation between cytosterolemia and familial hypercholesterolemia is very crucial in these patients, because cytosterolemia does not respond to statin, but they respond dramatically to ezetimibe. So if the patient has got cytosterolemia and you continuously give the patient statin, this patient is going to have poor response, and then in fact you are also aggravating the progression of this disease. So it is very important to differentiate between the two. And then the absence of coronary artery disease or hyperlipidemia in both parents is a clue that this patient may have cytosterolemia, because we say this is an autosomal recessive. So the parents may be carriers. And generally they thought, it's been understood that in the carriers, they may not phenotypically present with hypercholesterolemia. So the parents may be normal, but then the siblings, like in this case, the siblings were dying of premature, atherosclerosis, but the parents were not affected. So the other thing that is important is to know that the plant-based foods that are typical, the plant-based foods are typically encouraged in familial hypercholesterolemia to help reduce LDL cholesterol. So this is what the doctors would typically prescribe for those patients with familial hypercholesterolemia, because these plant sterols, their absorption, they compete with cholesterol for absorption. So in patients with familial hypercholesterolemia, then they assist in the reduction of of cholesterol absorption. So if you prescribe this diet, the Mediterranean diet, to the patient with cytosterolemia, then this can be detrimental to this patient. So it's very important to know to differentiate between the two. All right. So treatment of patient with cytosterolemia, it's just a diet of plants or of plant sterols and shellfish sterols. So you avoid those olives, your avocados, your nuts, your seeds, your chocolate, and your margarines. And then you give them the sterol absorption inhibitor, ezetimibe, because they really, do very well on ezetimibe. And of note is that cytosterolemia does not respond well to statin treatment. All right. So in conclusion, both of these conditions, cytosterolemia and lipoprotein X-induced hypercholesterolemia, they are unusual causes of hypercholesterolemia that can easily be misdiagnosed as familial hypercholesterolemia. I wanted to say to you, previously that, in pediatrics, what they normally do is that, if their patients, like at the age of 8, 12, presents with premature cardiovascular diseases, and then the patient has got xanthomas, and then and there's no family history, and then they do the genetic testing for familial hypercholesterolemia, and it's negative. What they call it now, they call it a pseudo homozygous familial hypercholesterolemia. So they don't go further and investigate, because now then they start these patients on statins, and that is why now they come in adulthood and to internal medicine, to the physicians now with chronic dyslipidemia. Like this patient who is coming with Achilles tendons, which have been there since childhood. So it may be a case of a patient who was, given statins from childhood. Now this patient is not, they see, it's no longer responding, and then they send, now it's a grown-up, sent to internal medicine for further management. So they can easily be misdiagnosed as familial hypercholesterolemia. So differentiation from familial hypercholesterolemia is very crucial, as the standard statin therapy is ineffective in both of them. All right, and may potentially be hepatotoxic, because remember, your statins are being excreted in bile. So if you have spaces like in these patients with lipoprotein X-induced hypercholesterolemia, there is spaces. So you give them statins. Those statins will accumulate there, and they can even reach toxic concentrations there. So prompt diagnosis is a key to potentially prevent adverse outcomes for these patients. So we have to create some awareness so that doctors, even if they say these conditions are rare, they are aware of them, and then they can, think about them when you have your patients that are not responding to your statins. So to just think, and then especially in these patients with lipoprotein X, I mean, it should be at the back of our minds that if these patients are presenting with cholestasis and they have hyperlipidemia, it could be due to this lipoprotein X. So the management is different from treating an ordinary, hypercholesterolemia. So we need to be aware of that. Okay. So I think that was my next slide. Thank you.
Thank you so much. I think it's as we say, you can't diagnose things that you don't know. So hopefully we've all been made aware and reminded and all really thought about this. Thank you so much. I don't know if there's any way of how do we see if there's anybody online.
Do we